Cervical spine X-ray in trauma. Clinical considerations are particularly important in the context of cervical spine injury. This is because normal C-spine X-rays cannot exclude significant injury and because a missed C-spine fracture can lead to death, or lifelong neurological deficit. Clinico-radiological assessment of spinal injuries should be managed by experienced clinicians in accordance with local and national clinical guidelines. Imaging should not delay resuscitation. Further imaging with CT or MRI, not discussed in this video, is often appropriate in the context of a high-risk injury, neurological deficit, limited clinical examination, or where there are unclear X-ray findings. Standard views. The three standard views are lateral view, anterior view, posterior view or anterior-posterior view, additional odontoid peg view or open mouth view. Additional views. If the lateral view does not show the vertebrae down to thoracic spine, then a repeat view with the arms lowered or a swimmer's view may be required. Lateral view. The lateral view is often the most informative image. Assessment requires a systematic approach. Cervical spine systematic approach of normal lateral X-ray. Coverage. All vertebrae are visible. From the skull base to the top of T2, T1 is considered adequate. If T1 is not visible, then a repeat image with the patient's shoulders lowered or a swimmer's view may be necessary. Alignment. Check the anterior line, the line of the anterior longitudinal ligament, the posterior line, the line of the posterior longitudinal ligament, and the spinolamina line, the line formed by the anterior edge of the spinous processes, extends from inner edge of skull. Green anterior line, orange posterior line, red spinolamina line. Bone. Trace the cortical outline of all the bones to check for fracture. Note: the spinal cord, not visible, lies between the posterior and spinolamina lines. Disc spaces. The vertebral bodies are spaced apart by the intervertebral discs not directly visible with X-rays. These spaces should be approximately equal in height. Prevertebral soft tissue. Some fractures cause widening of the prevertebral soft tissue due to prevertebral hematoma. Normal prevertebral soft tissue narrow down to C4 and wider below. Above C4 is less than or equal to 1/3 vertebral body width. Below C4 is less than or equal to 100% vertebral body width. Note: not all C-spine fractures are accompanied by prevertebral hematoma. Lack of prevertebral soft tissue thickening should not be taken as reassuring. Edge of image. Check other visible structures. C-spine normal anatomy. Lateral detail. Bone. The cortical outline is not always well defined, but forcing your eye around the edge of all the bones will help you identify fractures. C2 bone ring. At C2 axis, the lateral masses viewed side-on form a ring of corticated bone, red ring. This ring is not complete in all subjects and may appear as a double ring. A fracture is sometimes seen as a step in the ring outline. Anterior-posterior view. Although often less informative than the lateral view, this view may nevertheless provide important corroborative information. A systematic approach is required. C-spine systematic approach of normal view. Coverage. The anteroposterior view should cover the whole C-spine and the upper thoracic spine. Alignment. The lateral edges of the C-spine are aligned, red lines. Bone. Fractures are often less clearly visible on this view than on the lateral. Spacing. The spinous processes, orange, are in a straight line and spaced approximately evenly. Soft tissues. Check for surgical emphysema. Edges of image. Check for injury to the upper ribs and the lung apices for pneumothorax. C-spine normal anatomy of open mouth view. This view is considered adequate if it shows the alignment of the lateral processes of C1 and C2, red circles. The distance between the peg and the lateral masses of C1 should be equal on each side. Note: in this image the odontoid peg is fully visible, which is not often achievable in the context of trauma due to difficulty in patient positioning. Open mouth view rotated. The distance between the peg and the lateral processes is not equal. Compare A right with B left. This is because when the image was acquired the patient's head was rotated to one side. Alignment of the lateral processes can still be assessed and is seen to be normal. C-spine normal anatomy. Swimmer's view. Oblique image with the humeral heads projected away from the C-spine. The cervicothoracic junction can be seen. Check alignment by carefully matching the corners of each adjacent vertebral body, anteriorly and posteriorly.